This conference will now be recorded.
So we're back reviewing ASCO 2024. We've done this before with GU ASCO 24 and ASCO 23 and GU ASCO 23, and we have a system, and that system is down to Mr. Ben Nathanson, who makes the slides and does a fantastic job producing this little effort. And there are four of us presenting, including Ben. But I just want to thank Ben for getting everybody organized. And with that, I'm going to turn it over to Ben to get us started.
Thanks, Rick. Hello, I'm ANCAN moderator Ben Nathanson, and today we're presenting prostate cancer highlights from one of the world's largest oncology meetings, the ASCO annual meeting. You'll be hearing summaries tonight from Rick Davis, John Antonucci, Len Sierra, and myself. More than 40,000, as you can see, oh, oh, more than 40,000 doctors attend these conferences. Okay. More than 40,000 doctors attend these conferences. The annual conference has fewer prostate cancer papers than there are at the ASCO GU meetings, but prostate cancer still got dozens of talks this year and 100 poster papers. We'll be discussing about 20 of these presentations tonight. We'll have 25 minutes for a Q&A afterward, and tonight's talk is being recorded. We'll make tonight's slides available, and the slides will give you many links. Slides that are about a paper have a link to that paper. At the top of the page, top of this page 2 in your slides, is a link that will call up every prostate cancer abstract from the conference. Our email addresses are also on this slide, so feel free to email us. John and I are ASCO patient advocate members, so in addition to answering your questions, we may be able to give you additional information about a paper that ASCO may have made only available to participants who are members. So, although this is a fancy conference, the creme de la creme, remember the conference papers haven't been peer reviewed. They're more like breaking news. And of course, nothing here tonight is medical advice. So we're ready to begin. Rick will start us off.
Good, and a quick shout out to all of our sponsors that allow us to do this: Bayer, Novartis, Johnson & Johnson, Myriad, Telix, and Blue Earth. So I have the honor of kicking off this august crew, and the theme of what I'm going to talk to you about tonight is very much precision medicine. 4 papers, 3 of which are really focused on why precision medicine is important and why we continuously insist that you get sequenced. So the first paper really looks at precision medicine and Pluvicto. Because not everybody is necessarily a good candidate for Pluvicto. You guys already know that, because if you don't produce PSMA, there's nothing for the Pluvicto to grab onto. But in addition, there are 3 bad bro actors in terms of mutations: TP53, RB1, and PTEN. They're what are called the tumor suppressor genes. They don't suppress when they're mutated. They don't suppress these tumors the way they should do, and they signal very aggressive, difficult to treat disease. And it's even worse when you have them in combination. These mutations are pretty common somatically, and in fact, P10 and TP53 may show up in up to 30 to 50% of advanced cancer. RB1 is a lot less prevalent, but it's there, and we've had plenty of guys who have RB1. The mutations germline are less common. TP53 Leaf Ralmani is not very common at all, and RB1 and PTEN even less so. But you can have these genes germline. So in a small study which was conducted at UCSD, they looked at 115 men who had Pluvicto, and what they found was a lower percentage of men reaching a PSA reduction of 50, PSA 50, if you had one of these mutations. It wasn't huge, 44 versus 56, but it was significantly different in terms of overall survival. 10 months less, 12.2 months from the time of Pluvicto versus 22.6 months. Conversely, if you had a homologous repair, homologous recombination repair mutation, like in the BRCA family, and especially if you had ATM, you may even have had a better outcome. So there are a number of other studies that looked at this. Ben and I were talking about one this morning, which was focused on CDK, which might have had slightly different results. That was done at the James. There was another paper out of Vancouver that suggests that ctDNA could be a marker. The heavier your tumor, the tumor fractions, the more likely the drug is going, the Pluvicto is going to be a success. But the bottom line is, get sequenced before you start Pluvicto, and if you show one of these mutations, these bad boys, then talk to your doc. The second slide that I'm going to go on to, that's the cue, Ben. The second slide that I'm going to go on to, there you go, is stays right in this area, and it looks at these three genes again, TP53, RB1 and PTEN, and looks to see how you do if you are using an androgen receptor signaling inhibitor, which is abiraterone, darolutamide, enzalutamide, apalutamide, or you're on a chemo or docetaxel. And here, our friends at FMI use their Flatiron database to look at men with metastatic hormone-sensitive prostate cancer. And they found a lot of men, almost 5,400 almost, and 571 of those men had these mutations. And then they looked to see what the outcomes were. And they found that if you had RB1, you had a 3 to 4 times worse outcome for overall survival and time to castrate resistance for the RCs, ARSIs, although you did quite a bit better on time to castrate resistance if you took on chemo. For TP53, they were 1.5 times worse for the RC, for the ARSIs, but only 15% worse on chemo. And PTEN didn't seem to make a lot of difference. Now, you have these in combination, it's going to be a bigger issue. So the takeaway again is make sure you get sequenced and know what somatic changes you have, and obviously what germline changes. The third slide that I'm going to talk about we're moving away from these TSG mutations, tumor suppressor growth mutations, and we're going to look at the BRCA genes, the homologous recombination repair or deficiency genes, and particularly at BRCA. And as most of you know, if you have a BRCA mutation, then you could be a very good candidate for a drug called a PARP inhibitor, of which there are several. Now, the only issue is, and we know this because we've seen it, and a couple of our favorite volunteers have actually expressed this, including one who is with us tonight and may own up to it, that they had a somatic BRCA mutation, and it reverted to wild type, meaning it went back to normal. So if it went back to normal, it was no longer a candidate for the PARP inhibitor. And UCSD studied this, and it's a pretty weird phenomenon. And they found 416 men with BRCA1 and BRCA2 alterations, and they found amongst them 25 experienced reversion, 3 of whom never got a PARP inhibitor at all, just like our gent in question. So they did say that they didn't have detailed records on all 25 of the men. And those who got a PARP inhibitor lasted 10 months longer with the PARP inhibitor if they were chemo naive. Because in fact, it seemed like the docetaxel and the radiation may have encouraged the reversion. So the takeaway is, if you've got a BRCA mutation and you're going to use a PARP inhibitor, do it sooner rather than later if you need to, and do it before your docetaxel. That seems to be the takeaway. And moving on to my last slide, it's not, this is, hold on a minute. There we go. This isn't Groundhog Day. Yes, we've talked about this before. We talked about it in our June the 3rd recording and in the June the 11th reminder. But this is a study, a paper presented that tells us that oxybutynin, which is ditropan, that's the commercial name, is a drug that can be used to successfully combat hot flashes if you're on abiraterone and an LHRH drug. Now, oxybutynin is an incontinence drug, and as we found out in our June 3rd recording, thanks to Dr. Jeff, it does have side effects: sleepiness, fatigue, rapid heartbeat. You can listen to the recording. A small double-blind trial of 88 men, and this was done at this was done at Mayo with Dr. Brad Stish. Reported that 70% of the men had improved results for frequency and intensity. So if you're on abiraterone, you might want to talk to your doc about oxybutynin. Now, why only abiraterone? Because the Ide brothers, enzalutamide, apalutamide, darolutamide, they use the CYPA3 pathway, as does the oxybutynin. And so the oxybutynin will change the strength of that drug. So it doesn't work with abiraterone. So if you're on Abby and suffering from excessive hot flashes, speak to your doc. The last thing I just want to mention, and it was in the reminder this week, is that I also learned that there are some supplements that use that CYPA3 pathway, including American ginseng. So some of you guys have been talking about American ginseng. Talk to your doc if you're on one of the Ide brothers, because it may not be good to take American ginseng whilst you're on darolutamide, apalutamide, or enzalutamide. And with that, I say thank you, and I pass it on to the next presenter.
Thank you very much, Rick. And our next presenter is John Antonucci.
Hi, everybody. Thanks, Ben, for being producer, director, and co-star. Like Ben already told you, this was an enormous meeting. There were panel discussions, oral presentations, poster sessions, everything you could ask for, probably including wine and cheese parties, but those of us who attended virtually couldn't go to those. My assignment was to review and present on the oral presentations. And oral presentations included case discussions, active research, reviews on topics, panel discussions. And it's a nice thing to have, because the oral discussions, I think, probably the best of all the work presented are awarded the chance to speak orally. So I'm glad to do that. Before I get into the research, there were a couple of clinical reviews to catch up all the oncologists on things that I wanted to call your attention to because I liked them. One was Vanderweiler's practical approaches to genetic testing and treatment selection in prostate cancer. It catches you up really nicely with all the genes that Rick was talking about and relevant mutations, particularly for high-risk people like us. And another one I like was Dr. Chen's one on imaging, catching us up on particularly PSMA scans, which scans to choose, what's the difference between them, when to use them, a little bit of information about neuroendocrine cancer. If you would like to see a summary paper, easy to read pretty much about these particular reviews, just contact me and I will send you a link or the paper itself.
This link will work too when people get the slides. They'll be able to click on this.
Okay. Next slide. There was a section, I think oncology in general has been very much aware in recent years about how miserable it is to be on ADT. And I think a lot of oncologists and even urologists are really trying hard to make it tolerable for us. So there was a panel discussion where everybody gave their ideas about how to make life a little bit better on ADT. Dr. Audio's section had to do with metastasis-directed therapy, in which he described how using radiation therapy for metastases could help for either recurrence or even de novo, could help to defer ADT in some cases, have us spend a little bit less time on ADT. She spent time describing who could use this strategy and who are the people in which there are no ways to avoid ADT. And those people with CRPC who ended up getting stuck pretty much with continuous ADT. Sach David did a little bit different angle on it. He picked out a topic that I think Rick often talks about in group, which is bone protective or bone resorptive agents, and described to the audience strategies for using these agents in order to reduce fracture risk, which they do, when to use them in metastatic hormone-sensitive prostate cancer, to use them always in metastatic castrate-resistant prostate cancer, how to use vitamin D and calcium and monitor renal functions, how to do dental checkups for side effects, and how long to go on with these drugs. The third section that I just want to mention quickly is palliative care, which we're always promoting in ANCAN. Behavioral therapy, cognitive behavioral therapy, looked a little bit at NCCN guidelines. And again, the reminder like we had in previous meetings about getting into palliative care earlier. Next slide. Metformin, many of you have heard about metformin. It's an anti-diabetic drug and a pretty good one. It generated a lot of excitement in past years for possibly slowing down the progression and incidence of prostate cancer. I know when I got first put on metformin for ADT-induced diabetes, my oncologist was actually quite pleased that I was put on the drug. But somebody has finally done a randomized controlled study, which you saw from my previous invite a few months ago, is pretty much the best kind of study you've done. It's a little bit not relevant for those of us in high risk because it was done with very low risk subjects. But unfortunately, despite all this previous intriguing evidence, metformin completely failed to delay progression in men as they develop prostate cancer. So it's not a drug for us to seek, at least for this particular indication of slowing down prostate cancer. Next slide. I talked a little bit about this particular study after GU ASCO, and we talked about the fact that in this study, which compared enzalutamide and ADT and enzalutamide alone, people whose PSAs fell down to below 0.2 actually got a treatment break. And treatment breaks worked out pretty well in general, but this particular presentation about the EMBARK study had to do with the quality of life. Now, it's not going to surprise any of us that treatment breaks improve the quality of life for all the groups in the study. And pain didn't really have a big difference, but that's because pain levels were pretty low in the beginning. And so the reason for doing what to us is an obvious study is to clear up some confusion in the literature. It really, and also to just inform all you folks that the oncological community is really interested in finding safe ways for us to get treatment breaks in order to improve our quality of life without endangering us from getting relapses. Next slide. You've probably heard us mention alpha radiation from time to time. There's only one of us, and I think I saw him here today, who has gotten alpha emission therapy. You know, radionuclide therapy now, for us, we're getting used to the idea of Pluvicto, which emits a kind of radiation called beta radiation right next to the prostate cancer cell and tries to kill it. Alpha is a different kind of radiation. It's a much bigger particle. It doesn't penetrate as much. It might be safer in some regards. And so I'm glad to see that people are working hard on finding new alpha emitters. This particular study by Morris took my attention. It's a treatment called JMJ6420. And what was good about it, I thought, is because they located a new target on prostate cancer cells, a protein called HK2. We always like new targets that we can aim at. There was a brand new antibody developed to bring the payload of the alpha emitter to the target. And it used, and as I say already, it had the novel quality of using a different emitter. Here they set it up against metastatic castrate-resistant prostate cancer, and it did quite well, with almost half the people having a drop in their PSA by 50%. It's way too soon for prime time, but I thought it was really of interest because it might be something we see in a few years might be good for us. So it's going to head into phase 2 studies now. I looked at the side effects, and they were pretty tough on red cells, white cells, and platelets. So a new kind of therapy that will be coming up soon. Next slide. Another novel type of therapy, you know, we take all kinds of medicines and do all sorts of things in order to interfere with testosterone getting to the androgen receptor. Most of the drugs that we take in our first few years of therapy have to do with that. And this pathway is really important too in the development of resistance to treatment. But there's a relatively new idea now of actually sending a missile to the androgen receptor itself and trying to damage it so that it won't be there in order to activate and help our prostate cancer grow. So here Dr. Petrolak presented ARV-766, which is the research name for an androgen receptor degrader in castrate-resistant prostate cancer. You have to have a way of targeting the androgen receptor, and this team has found a way of actually attaching to the androgen receptor not only the wild type that we have at first, but all the mutations that develop as resistance comes on. So this was investigated in early phases to see what the best doses were, and a decent dose was established, and for safety, and it was reasonably well tolerated. The subjects were like many of us who have had previously many treatments. The clinical effect against tumors with androgen receptor mutations was quite good. We may see androgen receptor degraders coming on sometime in the next few years. I don't know. Next slide. Neuroendocrine prostate cancer we worry about because our prostatic adenocarcinomas can actually transform over time into a different type of cancer called neuroendocrine cancer. It's difficult to detect and it's very difficult to treat. And it doesn't help any that prostate cancer cells are particularly resistant to immunotherapy to begin with. So in this study, Dr. Agarwal attempted to target a protein found on neuroendocrine cancer cells called DLL3 and not found much elsewhere. So far, he's had about 40 subjects in the study. It's just ongoing. It's not a double-blind study or a controlled study at this point. It's just an early phase 1 design and used an immunotherapy, a T-cell immunotherapy against it. So far, this drug, tarlatamab, is showing what they called manageable safety and encouraging response against neuroendocrine prostate cancer. Again, not near usefulness yet, but it's very nice for us to know that somebody is working hard on identifying, targeting, and attempting to kill neuroendocrine prostate cancer. Next slide. Excuse me. In prostate cancer, we are really on the losing end with immunotherapy. Our cancers are particularly, they have a disregard for immunotherapy. They have a way of cloaking themselves or making themselves immune to immunotherapies. And that's too bad because the natural immune system is one of our body's attempts to cope with cancer. So this particular study, Neptunes, is an attempt to try to figure out who with metastatic castrate-resistant prostate cancer might have overcome the natural resistance that prostate cancer has to immunotherapies. So he picked out progressing patients, in other words, patients that were already on treatment and were still advancing in their cancer, to find what he called a positive immunogenic signature, which is defined here in the slide. It's a way of finding out who, in theory, might be responsive to immunotherapy. And in fact, it turned out very nicely. The people with this positive immunogenic signature did actually respond better, although they did have a lot of toxicity. This is going to go on to phase 3 soon, and it might be helpful to identify some of us that might respond to immunotherapy. Last slide, please. A very few of us have tried this intriguing therapy, bipolar androgen therapy, and so far there's no way to figure out who's going to respond to it and who's not. And it's very important because by the time we try bipolar androgen therapy, we don't have a lot of time to fool around and waste with treatment failures. Well, in this particular study, subjects who were recurring on abiraterone and ADT had an assessment of their cell-free circulating DNA in their blood. And then they were sorted into 2 categories. Those that had mutations in androgen pathway mutations and amplifications in the androgen pathway genes, and those without. And it turns out that the people that did have these particular mutations had a significantly better response to bipolar androgen therapy than to enzalutamide, and the ones that didn't have those mutations, the opposite was true. Therefore, anybody considering bipolar androgen therapy, I think, should have liquid biopsy done before starting out so that you can have a prediction of your results. Thank you.
Thanks very much, John. And next will be Lynn Sierra.
Okay, thanks, Ben. All right, first slide. Doublet faceoff, ADT plus chemo versus ADT plus androgen receptor pathway inhibitors, which hopefully we all know by now are the lutamides, darolutamide, enzalutamide, apalutamide, and abiraterone. So the study evaluated the overall survival and time to castration resistance in patients with de novo metastatic hormone-sensitive prostate cancer in the Veterans Health Administration treated with this doublet combination therapy. Just to give you an idea of the size, this was 1,226 patients whose records they accessed. And as you know, de novo means at diagnosis, these people were already metastatic. So what they found was that in both high volume and low volume metastatic hormone-sensitive prostate cancer, docetaxel showed a shorter real-world progression-free survival, but there was no difference in overall survival. Now, if you're wondering what's meant by real-world, it's just to contrast it to what you see in clinical trials where everything is carefully controlled and the patients are recruited, with certain inclusion and exclusion criteria. So real world is, once you get outside the arena of the clinical trial, the drug is approved, now it's out there among the masses. And so this is what they determined, that although there was no overall survival difference, whether you had ADT plus chemo or ADT plus a second line anti-androgen, there was docetaxel showed shorter progression-free survival. So that makes me wonder how valid progression-free survival is in clinical trials when apparently it's possible that there may be no difference in overall survival. Next slide, Ben. Okay, in triplet trials, who really needs chemo? PEACE-1 and Arisen's phase 3 trials showed benefit of triplet therapy. PEACE-1 was abiraterone plus ADT plus docetaxel. Arisen's was darolutamide plus ADT plus docetaxel. And they clearly showed benefit in patients with high volume hormone-sensitive metastatic prostate cancer. So the benefit was less clear in patients who had low volumes of disease, which was defined as less than 4 bone mets and no visceral mets. So to address this uncertainty, investigators are conducting a phase 2 trial evaluating ADT and abiraterone versus ADT abiraterone plus docetaxel in patients with low volume metastatic hormone-sensitive prostate cancer. And so if you're anybody's interested in enrolling in this trial, there's the link to the trial. All right, and final slide for me, ranking PARP inhibitors for bone marrow complications. As you folks may know, there are 4 approved PARP inhibitors: olaparib, niraparib, rucaparib, and talazoparib. And they have been approved either alone or in combination with androgen receptor pathway inhibitors. So the aim of this study was to help the clinicians decide, well, which one should I choose for my patients? So they wanted to compare and contrast the myelosuppressive effects of these PARP inhibitors. And as it turns out, talazoparib had higher rates of myelosuppression in all categories. And the categories of I don't think we have that here, right, Ben, that chart? Yeah.
No, sorry. No.
That's okay. That's okay. So the categories of myelosuppression would be anemia, leukopenia, which is low white blood cell counts, thrombocytopenia, which is low platelet counts, and pancytopenia, which is low, uh, all across the board, low blood producing cells, marrow producing blood cells. And so talazoparib had the highest rate of myelosuppression in all categories except for thrombocytopenia, which is low platelets. And it was particularly pronounced in the case of leukopenia, which is low white blood cell counts. And in fact, it was 9 times, the percent was 9 times higher than what we found with olaparib, which is probably the most common PARP inhibitor used. So the takeaway, as I said, is that physicians can use this to determine which PARP inhibitors to use for their patients. And when this gets posted to our website, maybe we'll have the chart. And I think that's it, right, Ben?
Thank you very much, Len. That's right. You just
Thank
had
you.
3. And now it is my turn. So, in fact, Len has told us he's found the paper that shows that the PSA and PSMA PET don't always go the same way. You can't guess where one is going if you look at the other. And this is a small study. This is not something any more than thought-provoking. They were on enzalutamide monotherapy, and after 3 months, they were tested 2 ways. Their PSA was tested, and they had a PSMA PET. And 5 of these people had a PSA response, but no response in their PSMA PET, and 11 had it the other way, PSMA response, but no PET response. So, and you notice on the right here that these were very different patients. They had very different outcomes. Um, um, and if you look at the overall survival chart. So it's food for thought. It's you can't necessarily tell from your PSA that how well the treatment is working. And similarly, PSA PET alone, interestingly, may not reflect PSA. A question we're always asking is how do we find out whether we express PSMA? So they're on it. They're trying. They wondered what can we look at in a patient that would tell us that the patient expresses high PSMA? So they they looked at more than 7,000 specimens. They looked at DNA. They looked at RNA, and they looked at PDL1, which is um, an immuno protein. It had an august, it's a paper we could take seriously because it includes Rana McKay, who gave the paper, Misha Beltran, and Emmanuel Antonarakis. It was also done by employees of Caris. So they found some suggestive things. They found some things that they might look at further. They found that when you have ARV7, the splice mutation, which arises when you've been treated for a long time, and if you have specific changes in AR related genes on the androgen receptor pathway, not all of them, but some of them, um, that will correlate with higher PSMA. It's higher PSMA tends to run along with more inflammation and less neuroendocrine signaling. So it's not a recipe for finding, unfortunately, who's got the PSMA. Um, it did find that tumors with high PSMA expression are molecularly distinct, so there's hope here, providing insights for unique therapeutic strategies in this group. One interesting one interesting drug that hasn't gotten a lot of attention is CD46. It's the perennially promising next PSMA. It has wonderful characteristics. It's more specific than PSMA, so you don't have the salivary gland stuff. The only other place other than the prostate cancer where it shows up is in the placenta, and not many women are going to be given this drug. So it's marvelously specific. It's looking it's miraculously specific, and the miracle continues. It's just as effective, unlike PSMA. It's just as effective in neuroendocrine. Like PSMA, it's theranostic, meaning it can be used both for your therapy and for imaging. So in this trial, the warhead. This is a therapy trial. They use MMAE, a super toxic chemo drug, and they give enzalutamide as well. And to tell you the truth, the side effects are completely disappointing. Neuropathy in half the patients. This isn't supposed to happen if the drug is specific. Um, but it does have the NEPC angle, and it's still early. They're still sussing out this drug, so it has a lot of potential, but that's all that it is. So um, they looked at I'm sorry, I forget who they is one of the labs that does DNA sequencing. They looked at tumor samples, and they found 128 of them had a sort of unique mutation. They weren't mutated in our normal sense. They were genes that were fused together. Two genes were in one gene location. Um, 128 out of the 8,000 some. And on the other hand, it's just 1.5%. So there's already a very well-known fusion that causes prostate cancer. But that's not this. This is something brand new. Most involved the BRAF. Um, and what's interesting about these is that they seem to be a completely separate mechanism from AR that we keep hearing so much about. So they could, in fact, be a new target. And you know, you say 1.5%. Who cares about this? But of course, if you're the 1.5%, this is incredible. So that's how precision medicine is. You chip away. There's the exciting news about AIA is no longer novel, but the exciting news, or the potentially exciting news, continues to come in. One amazing thing, nice if they could do it, is to predict overall survival in a clinical trial. Uh, a big problem, Len was talking about this a little earlier, a big problem in clinical trials, that the number that you want, the thing that you want to know is, will the drug help you live longer, the overall survival associated with that drug. And to do that, you have to wait for patients to die. And in prostate cancer, that takes a long time. So not only does that make the trial expensive, it also means that you, at the end of the pipeline, waiting for the drug to arrive, have to wait that much longer. So everybody who does clinical trials is looking for a shortcut. Um, and some people use, as Len was saying, progression-free survival as a shortcut. Um, this may be, this is hopes it can be the holy grail, that by running AI on this or that, that you could predict um, way ahead of time who's going to die sooner, and you can end your trial lickety split. So there are two existing efforts to crunch the data and try and figure this out. Um, one interesting question is who's going to benefit from oligometastatic therapy? Sometimes, um, yeah, it works better in some people than others, as you might expect. And the purported claim, the claim here for AI, is that you can test people to see who's going to really benefit from spot radiation and who's not so much. And finally, so Decipher, among other things, will give you a forecast on your illness. It will tell you how long you're likely to live and how long you're likely to recur. It looking at the sample after your prostatectomy. But to do that, it has to do RNA sequencing, which is lab work. It's expensive. It takes time. This would just look at your slides, the slides that were already made from your prostatectomy, and tells you both numbers. No muss, no fuss. So just taking a quick, I'm out of my time. So that will suffice. You can certainly ask me about details on any of these things. The fact is, as you can guess, the hype is bigger than the delivery. These things have a long way to go. They don't really show the kind of promise you would hope. So actually, I'm next. Um, Steve Schuler and I worked together on an AI roundup. I'm sorry, this is, I'm sorry, so that is in fact the end of my presentation. I gave you the AI roundup without realizing it. And we have time now for questions.
I can start off with a couple questions while the guys are thinking. Um, Len, you mentioned about a study in which progression-free survival and overall survival contradicted each other. And I noticed this has come up a couple times. So could you guide us a little bit about when to pay attention to progression-free survival, when to pay attention to overall survival? Is progression-free survival useless if we have OS data? Could you, it takes a lot shorter time to get progression-free survival than overall survival, but could you just tell us a little bit about those two kinds of outcomes?
Yeah, sure, John. Well, certainly, as you suggested, if you have both progression-free survival and overall survival data, the overall survival data is certainly the most important, and you can pretty much ignore the PFS, progression-free survival. It's apparent. I guess it's as Ben mentioned, it takes a long time, thank goodness, for a lot of prostate cancer patients to die. So overall survival is not a very practical measurement for the FDA to determine if a drug should be approved or not. So they have to, it's almost a necessary evil. They have to default to progression-free survival, which is typically much shorter than overall survival in time. I don't know, did I answer the question?
Yeah, thank you. And one for Ben.
Actually,
Um,
I'd like to say something about the previous question. Um,
Please do.
I don't turn up my nose at progression-free survival. Rick helped me think through this one. Um, it's it's it gives you runway. It gives you time till your next therapy. It gives you some opportunity to coast while you're looking for the next therapy. The time when you start to progress is the time when you have to start shopping for a new therapy, and the time you start despairing a little more about your prognosis. So having a good progression-free survival, even in and of itself, even if there's no impact on overall survival, um, has its benefits, and also it what overall survival is murky to me at least in patients who've been treated with this, that, and the other thing. Um, you know, how can a trial actually measure overall survival? How practically can a trial measure these kinds of things? It's silly to insist on it. You do need some kind of proxy. I mean, even if you had the patients to wait, you would be denying these patients alternative care, therapeutic alternatives while they waited, which is insane. So I don't think that we can disregard PFS even when that's all we have.
Yeah, I don't disagree with any of what you just said, Ben.
Are there audience questions, or should I ask another one to give you a little more time?
I've got one.
Yeah,
Oh, that
Gary
sounded like
Peters.
Gary. Okay.
Um, thank you guys for doing this. Um, Rick, a question about one of yours. You said before you do Pluvicto, you should get sequenced. And is that, when you say that, do you mean both germline and somatic sequencing or just somatic? And also, do you mean you should get sequenced again, even if you were sequenced before?
Yeah, the second part of your question is really good. Just somatic is fine, because it doesn't really matter if the mutation, from the standpoint of the Pluvicto, it doesn't matter if the mutation is somatic or germline. We don't think it makes a difference. If we found a mutation in the somatic that could be germline and you weren't aware of it before, we can check and just do a germline test, because that's going to be important for any of your relatives. But basically, just somatic is initial is adequate. The second part of your question is very important. Um, if you have not been sequenced recently, it's my view that you should get sequenced again, um, because the sequencing changes, as you saw with the BRCA slide. So mutations can change and they can go back to they can become normal again. And we just had this issue with Frank Fabish last week, where we told Frank, please get sequenced again, because we want to make sure that that wild type, that BRCA mutation has not reverted. So please ask Dr. Mordasavi to make very sure that you still have a BRCA mutation. Is it okay to identify the person who had the BRCA mutation that went away or not? I'm not seeing a thumbs up from that person, but one of our gents here had a BRCA mutation, and it went away. So it was somatic, and then it went back to wild type. And if we would have based it on when he got the mutation, when he got the original testing, and given him a PARP inhibitor, it wouldn't have made a difference. And these drugs are toxic. Does that answer your question, Gary?
Yes, one follow-up. Isn't Keytruda also a PARP inhibitor? Because I didn't see that listed.
No, it's not. It's an immunotherapy. It's an anti-PD-1 drug. It's an
Okay,
immunotherapy drug.
okay, thank you.
Mark Baldridge, I see your hands up.
Yes, yeah. Thank you very much to the presenters. There's a lot of good food for thought. My based on these presentations, I mean, it seems exciting that there's a whole wide variety of possible treatments up ahead. But what I'm wondering is does a group like ours need to somehow kind of advocate for, I mean, maybe there's like two or three kind of realms of treatments that we feel are most important to us. I mean, um, would this be useful to try to advocate to somebody? And I'm not even sure who that would be. You know, the drug companies, the government. I'm not exactly sure how all this research is funded.
Rick, you're the Advocate General. You should speak up.
Um, I guess, Mark, I'm not exactly clear what you want us to advocate for. I mean, give us a specific example from. I mean, we're talking to the drug companies quite a bit. And we try to give them feedback. We try to give them feedback on how they design their trials. We try to give them feedback on what type of trials we want. We've been advocating for trials for the use of monotherapy ARSIs or ARPIs for ages, and now they're listening to us. Well, we saw the Embark study. I think Johnson and Johnson is doing something with apalutamide. We know that Bayer has got something in the works for darolutamide. Not so sure about what's going on with abiraterone, especially since it's generic at this point in time. But we are advocating all the time. So where specifically are you looking at for our voice to be heard? We're trying to make your voice heard all the time.
Yeah, I mean, I was, yeah, I mean, like it was mentioned, like neuroendocrine cancer, and the how to try to prevent prostate cancer from
Yep.
going to castration resistant. Yeah, I just wondered. Yeah, no, it sounds like you said, Rick, that we're in good communication with a lot of drug companies. So I think maybe I just didn't understand. I just wondered if there's like these are like our top priorities for treatments that we like based on the experience of the group. But it sounds like it's well covered.
Well, so, when it comes to, say, the neuroendocrine cancers, I mean, we're as anxious as the doctors are. I just listened to Tanya Dorff do a little 2-minute talk on that today. She was interviewed at ASCO. They caught her and she said a few words. I mean, we're talking to Misha Beltran and Rahul Agarwal about, what can we do? Or we have guys that might be in this boat. What do you suggest? For the key medical issues that are out there, I think that the doctors that we know and trust are very anxious to find solutions just as we are. Len, I see you have your hand up. Did you want to say something on this topic?
No, it wasn't this topic, Rick.
I could add a little something to it.
Please, John.
There are a lot of organizations that fund prostate cancer research. Some of them are private. They think that a new drug can be discovered and they can make money off of it. And many, like National Institute of Health, Prostate Cancer Foundation, the CDMRP, are public organizations. But you might be interested to know that in some of these cases, especially the public ones, they do want to hear from us. And in the case of the congressionally mandated funding that's about $130 million a year for prostate cancer research, they actually have some of us sitting on their review boards, reviewing proposals in order to say what would be of the most benefit to us from our point of view, and it influences how they distribute money.
Yeah, that's a
And,
good
and I
point.
just want to add that 3 of the 4 presenters tonight do that work, and it's very time consuming, and we're really grateful to them. I don't, so you can figure out who does, but they really, we're really grateful to them. There's a lot of hours that each of these guys put into reviewing the papers and giving the feedback, and God bless them for doing it. Thank you. as we say to the veterans, thank you for your service.
This is a DoD program.
Yeah.
So, Len, what did you want to talk about?
Was that addressed to me,
Yes,
Ben?
sir. Yes, sir. You and
Right.
you
So,
alone.
so Rick was unsuccessful in trying to out someone who apparently had a BRCA reversion, but I wanted to mention, I don't know how many of the guys, we have so many fairly new guys. I don't know how many of them remember Carl Foreman or Dr. Bill Burhans, but both of those fellows had germline BRCA mutations that were successfully treated with PARP inhibitors for a couple of years, and then they both stopped responding. And the reason was that they had reversions to the wild type, the normal BRCA gene. So um, it's real. It happens.
Yeah, I mean it's real interesting because these guys had wild type, which means they inherited their mutation. They didn't make it themselves. And to my simple mind, it seems if you made it yourself, it's probably easier to revert for you to unmake it yourself. But both these guys, in response to their treatment, reverted to wild type. Now there's another person out there who had somatic and they reverted as well to wild type. So again, it's just really important. Know what you have before you embark on a treatment that might be impacted by the mutation. Whether you're taking something just because you have that mutation or because certain mutations might affect how it responds, and discuss it with your doctor. Because I do think sometimes the doctors don't think to recheck, and they should be. And so our job as in trying to make you your best advocate is to ask your doc, do I still have the mutation, doc?
Cancer is is a mutation machine. One of the first mutations you acquire is a mutation that makes you mutate more easily. There's all kinds of functions in the body that try and prevent um, unauthorized mutations, and one of the first things cancer does is defeat them. So it's not, it doesn't say I'm cancer now, I don't have to do anymore. It just keeps, it cannot stop itself from making more mutations. So it really is essential to keep up with your somatic mutations because they are ongoing. They will keep changing. So Jim Marshall, welcome to
Yes,
speak.
returning to the subject of somatic, um, requesting it, I take it I would ask for a circulating tumor cell test, a blood test. Is that right?
No, the
No.
circulating tumor test is actually a different measure, and
Okay.
it's not going to tell you what mutations you have. It's going to really tell you about how much cancer, how many cancer fragments are in your blood. What you need is a liquid biopsy if you're going to
Ah,
take it from your blood, and you just have to get a new liquid biopsy. But um, the time to get these is usually before, when you're at a treatment juncture. If you're in a place where you are fairly stable and you're not about to change your treatment, um, or you've been off treatment and your disease is rearing its head and you want to find the best treatment, that's the time to do it. But
okay.
I wouldn't say do it just for the sake of doing it, but do it before you're at a treatment junction. Would Dr. John, would you agree with that or not?
Yeah. Yeah.
Yeah, I think that's a really good clarification. And
I have a
just,
question for Ben.
oh, I was just going to say one more thing to to Jim. So it's not obvious, but liquid biopsies can sample one of two things. There are cells in your blood that slough off from the cancer, but there's also DNA, just DNA molecules in your blood that have also come from the cancer. And these are actually two different things. And um, so what's more typically done is that they look at the DNA that's floating around rather than the cells that are floating around. But you can get information from both things. So I'm sorry, John, what were you going to ask?
Regarding your showing us, clarifying that PSA is different from PSMA and that they don't necessarily co-vary. I like to think about guys who are on treatment holidays because I am myself right now on a treatment holiday. My success and duration of my treatment holiday depends on my PSA. But what you said, I think, is a warning against exclusively using PSA in order to tell us how things are going. Do you think it's at the point yet where, while we're on a treatment holiday being monitored, that we should maybe also have our PSMA looked at as well as our PSA, since they don't necessarily vary together?
I mean, to me, it makes great sense. Len, you were the one who found that Armstrong analysis, right? That
Yes.
that post hoc analysis that showed us very clearly that you cannot depend just on PSA,
Yeah, good
Yeah,
memory, Ben.
and
yeah.
that's something you could show your doctor if your doctor is uncertain.
Because I have not heard of anybody doing it. I know my guy is not interested in doing PSMA repeat unless and until my PSA goes up, and I haven't heard of any other guy on a treatment break who've been scanned when they're not showing PSA.
Well, of course, there is that conundrum that the quote unquote the PSA needs to be high enough for
Yeah,
the scan to be effective.
Yeah, no,
Yeah.
but I don't agree with that
Right.
conundrum.
Right. I knew you.
And the reason I don't
that
is
was a setup.
I think it's very important if you've got recurrence for the first time. But I don't think it's as important if you're known to be metastatic, because you may be producing PSMA, you may not be producing PSA, but we know you've got Mets. And just because you're not producing PSA because it's suppressed by something doesn't mean to say you're not going to express the PSMA from those Mets.
I mean, that's certainly a true thing, and we have seen people go in with recurrence and very low PSAs and get useful scans. It's really a question of how high does it have to be to persuade the doctor.
It's
I just want to take a quick opportunity. We can keep going until we move right into the support group, which we'll probably do in about 10 minutes. But just for the sake of the recording and the sake of everybody on the group, um, Ben has very graciously volunteered to split up the two recordings, um, one into the support group as normal, and the other into this session on ASCO 24. We will post both when Ben has completed his magic, and Ben will also, when he posts this to our blog, he will include a link to all of the slides. Okay, so don't worry if you didn't catch all the slides or you didn't do a screenshot or this, that, and the other. All of these slides will be available. The only person who has them all is Mr. Nathanson. I only have my slides, and it's probably true of everybody else, which is a good thing. So just be patient with us. And the other thing, and if you haven't figured it out by now, we are back in business in terms of letting you know when we post to our blog. If you're not finding that out, then you need to go to the Contact Us and click the new blog box in there, and that will send you an email when something new gets posted. It won't be instantaneous. It'll be early in the morning the next morning. It sends out a summary of everything posted the day before. We don't post that much, but you will receive notification. If you are getting it right now, that's great. We know a bunch of you didn't get um, notification of a bunch of recordings that were posted for about a month and a half to 2 months. Alexa was kind enough to send those all out last week. And there is a blog post now. If you didn't get it, you just go to the blogs and scroll through the blogs, and there's a blog post with a link to everything that was put on the blog where you might not have got a recording. That means all of the not got notification. That means all of the recordings. It especially means the wonderful effort that Captain Jim and Gail made on Memorial Day, where they put a table in front of their house, and we put that on the blog, and you can find that and a lot more good stuff. So that's what I wanted to say.
I would also like to encourage anybody that wants an overview, in order to present you with the studies that they did, Ben and Len had to eliminate probably, I don't know how many, but I bet you 150 poster sessions in order to present you with the 10 oral presentations that I did. I had to eliminate 24 of them. If anybody wants to try to get some sort of an overview, I urge you to take Ben up on his offer to look at those abstracts. I also have very brief discussions about all the oral presentations I looked at. So we can't really give you a huge overview, only a sampling, but you can get an overview if you look a little bit.
And in fact, there are videos of these sessions that are supposed to be for. Actually, this is a recording, so I'm not saying anything. You can infer the rest. So, I think we should formally end this for recording purposes, unless there are any further questions. So I thank you all for coming, and we're just going to hang around now till the